to speak to you today and to take part of this important meeting. My name is Arwa Younis, and I'm a research fellow here at the URMC and part of the American Heart Association grant, looking at the 6 differences in patients with long QT syndrome. Today, I would like to speak to you about the effect of menarche and biological life stages on cardiac outcomes among long QT syndrome females. So if we go back a little bit and speak about the effects of the 3 most common sexual hormones on the QT interval, we will see that estrogen, which is also known to be the main female hormone, can lead to a prolongation of the QT interval, which is obviously not good for patients with long QT syndrome. The other female hormone, progesterone, is associated with a shortening effect of the QT interval, which is good for patients with long QT syndrome. The male hormone, testosterone, can lead to a prominent shortening of the QT interval, which is actually excellent for patients with long QT syndrome. Therefore, generally speaking, the cutoff to consider a QTc interval pathologic differs significantly between males and females and is usually higher in females. If we look now at the hormonal change during the lifespan of a woman, so if we go and look at during childhood, we see that there is a slow increase we can combine these 2 lines, is the estradiol and the estrone, into estrogen. So there is a light increase over the years of the childhood. And then the puberty begins, and during the puberty, the first period happens, what we call menarche. If we look at the hormonal levels, we will see that before the kickoff of the menarche, we see an increase in the progesterone level, which was all the time very, very, very low, or and then continue to increase during the puberty and the adolescence, together with an increase in the estrogen. But also during the lifespan of a woman, she can have pregnancy. And if we look at the hormonal levels during the pregnancy, we will see that there is an increase of progesterone and an increase of estrogen during the pregnancy. And then during birth, there is a prominent decrease in both, but short after the birth, during the first months of the postpartum or the breastfeeding period, we see that the dominant hormone is estrogen and not progesterone, while during the pregnancy, the dominant hormone was progesterone. And then we will come to the 3rd biological life stage of a female, which is the menopause. And then we have an attenuation or a drop of the estrogen level, but we have a more prominent drop of the progesterone level. So at some point before the menopause begins, we have premenopause, we have a relatively much higher estrogen level than progesterone. I will be speaking about our study, which discussed these effects of these biological life stages on the cardiac outcomes among our long QT syndrome females. So the background for the study, the clinical background, we spoke about the physiological background, and now we're going to speak about facts. Women with congenital long QT syndrome experience increased risk for cardiac events after the onset of adolescence, as Dr. Goldenberg said before. So we can see that during childhood, before puberty, boys tend to have a higher risk for cardiac events than girls do. And then we have, at this age here, we have the onset of puberty, And then there's a risk reversal. While the risk for boys is slightly higher, um, but the risk in the females continue to increase and becomes much more and more higher than the risk in the males. The same with the probability of life-threatening events. We see that at the beginning, boys may have or at risk to have more life-threatening events, and then after the onset of adolescence and puberty, females are at a higher risk. There is also an important effect that we need to take into consideration is the onset of the menarche. So today we define a normal menarche if it occurs between 12 years to 16 years. If the first period would happen between the 12 year to the 16 year, the menarche onset will be defined as normal. Before the age of 12, we will say early menarche, and after the age of 16, we should start evaluating this girl for causes of this amenorrhea and to try to find why this girl did not have a menarche yet. So we call it late menarche onset. And generally speaking, I'm not speaking about long QT syndrome patients. This has a very significant effect on cardiac outcomes. So a recent publication that was published in the JAHA, the Journal of American Heart Association, showed that actually both early menarche onset and late menarche onset are associated with a very significant increased risk of cardiovascular events when compared to girls with normal onset. And that's why we wanted our aim in the current study was to evaluate these two aspects. First is the biological phases of a woman lifespan, and the other one is the onset of menarche. In order to do so, we sent a prospective questionnaire to our long QT female subjects, and we asked them to fill out these questions regarding their menarche onset and their contraceptive use, pregnancy, other things that were not captured before. Although the contraceptives and the pregnancy and the menopause were captured, but we just wanted to double check and make sure and to refill these important informations together with questions regarding menarche. Here we look at the distribution of our cohort. So 435 women answered our questionnaire. Of course, there is a bias in terms of people who survived to answer the questionnaire are the ones that answer the questionnaire. So obviously, if a girl died at the age of 20, she could not participate in this study. So we have this bias of 430 women that mostly survived this. We had some that filled it for their relatives, but that was very, very few. We can see that the majority or most of our patients or members have a normal menarche onset. We have 68 women that had a menarche onset before the age of 12, and we have 21 that had after the age of 16. So since going back in many cases, we did not know the exact date, we took this confidence interval of half a year. If we look at the baseline characteristics of our study cohort, we will see that the main age at menarche, of course, differs significantly and was 10 and a half years in the early group, almost 13 years in the normal group, and 16.7 in the late group. Patients with pregnancy, the number of patients or the percentage of patients with pregnancy did not differ significantly between the groups. And the average number of pregnancies per pregnant woman was also similar in all groups. Um, and then, as Dr. Goldenberg mentioned before, we censored our patients for some of the analysis, including the baseline characteristics. We censored them at the age of 40 in order to try and avoid the competing risk of cardiovascular event not related to QTC prolongation. The ECG at enrollment was also similar. The QTC was similar in all three groups, and the QRS width was also similar. The distribution of the genotype did not differ significantly and was also similar, mostly long QT2 patients, which is very important for our study because of the IKR effects, the effects of the estrogen and progesterone on the IKR mutation. Um, and then we had the what we called events prior to menarche or treatments prior to menarche, and we see that these also did not differ significantly between the groups. The treatment during follow-up, that means from the age of 0 to the age of 40, 32% were treated with oral contraceptives in the early group, 25% in the normal, and only 10% in the late group. Beta blocker was between 62 to 68 in all groups. We did not have any sympathectomy in the early. We had 2% only in the normal and none in the late group. And ICD was implanted around between 19 to 24% in the groups. And then we did something called Anderson-Gill modeling, which is a multivariate analysis looking at the effect of menarche onset on the risk of recurrent cardiac events in long QT women. And we can see that early onset of menarche was associated with a 86%, with a 31% risk reduction when compared with girls with normal. That means if a female had an early menarche, if we're gonna compare her to a female that had a normal menarche onset, her risk of having a cardiac event in life or recurrent cardiac events will be 31% lower. However, if a female would have a late onset or had a late onset menarche above the age of 16, then she has a 49% risk increase of cardiac events when compared with the normal group. And these results were adjusted for beta blocker use as a time-dependent covariate, and of course to the baseline QTC, and together to the age and birth decade of that female, and the genotype. This is an illustration of the findings that we discussed before. So if we will start looking at the cumulative, at the mean cumulative events per 100 patients, starting from menarche, we can clearly see that those patients who had late onset menarche had a significantly higher event rate than patients with early or than the normal. So early is the lowest, this is the normal, and this is the late onset menarche. Our results were consistent when we looked further into the future, because if we look at this figure, what I showed first and what I'm showing now, the time here begins at the time of menarche, and this might be a little bit problematic because then we will compare girls at the age of 12 to a girl at the age of 15, and in order to avoid this, we looked at whether this has an impact on the later stages of life, and then we started our follow-up at the age of 25 to avoid getting close because some girls had onset of menarche at the age of 20. So what would happen in the future? So, and the results were very consistent. Late menarche onset was associated with the highest risk of cardiac events, and early menarche seemed to be associated with a greater benefit or lower risk. And then we wanted to do stratification, or to look further into our specific genotype groups where we still had some power to do so. So among the long QT1 group, we saw that the onset, whether early or late, did not have a significant effect on the risk of cardiac events. That means in long QT1 patients, it seems to be that the onset date of menarche does not uh, affect significantly the risk of cardiac events. However, in long QT2 patients, um, we saw the results that we saw earlier, that early menarche is associated with a 48% risk reduction for cardiac events. And we saw that late is associated with 19% risk increase, which was not significant. In other patients, including long QT3 and other mutations and other negative, but coming from a family positive or genotype, what we call genotype negative phenopositive patients, we saw that the early onset was associated with a 51% risk reduction, and late was double the risk for cardiac events. And obviously, these models were also adjusted for beta blocker use, QTC, and birth decade. In this slide, we will speak about the event rate per 100 patient years in each lifespan period of a woman during her life. So we can see that we're going to take again childhood as our reference, and we see that during childhood the event rate is low, is still exists, and we know that children still may have or may suffer from cardiac events before puberty, but then puberty onset happens, and we see that there is a significant risk increase in the risk for cardiac events and the number of events. There is an attenuation during the maturity life. There is another increase during pregnancy. We know that pregnancy is associated with stress, and we know that there is an imbalance between estrogen and progesterone, which keeps switching. So it's not that the relationship between estrogen and progesterone changes over the time of the pregnancy over several times. So we see that pregnancy in comparison to childhood and in comparison to maturity is associated with an increased risk of cardiac events. But the most prominent significant risk happens to be during the postpartum period. And this is Dr. Goldenberg already published on that, a very nice paper, and describes the mechanisms that we believe it's the imbalance between the estrogen levels and the progesterone levels which leads to these findings. And then menopause happens and the risk decreases again. Summary and conclusion, it seems that in long QT females, early menarche onset seems to be protective, whereas late menarche is associated with poor outcomes. The risks seem to be influenced by the ratio between estrogen and progesterone and is more pronounced in long QT2 females. This information, we believe, may improve risk stratification in this special population. And we hope that hormonal studies, including our current studies, may improve the outcome of these females. I would like to thank Dr. Goldenberg, to thank our Chris, to thank Scott, and to thank Dr. Zariba, and to thank you guys for listening.
Thank you very much. So, Arwa, you presented very interesting data. We are obviously happy to hear comments, especially from Dr. Ackerman, who sees frequently children with long QT So, Mike, what's your take on some of our findings about girls around puberty and depending on the period, age at which they got period?
Yeah, I think Arwa, great presentation. It'll be interesting to look at that further. Obviously, I've never had a clinical impression with any of the patients of the onset of menarche early versus late. So it's an interesting observation for which I've never clinically been tuned into. So I think it may have to do with that observation may be mitigated once they're effectively treated, because I've never been struck by that. And you would think if it was impressive enough, we would have noticed it by now, because we've taken care of, plenty of adolescents, prepubertal, peripubertal. It might be interesting to go back and look at the question a different way as to those young women who had a sentinel event pre-diagnosis and therefore pre-treatment. Are you more likely to present with a sentinel event based on being early or late? Because I just think we may not have been in a position to see the observation that you've gleaned, because once they're effectively treated, maybe those issues aren't there. I do have a question from you, Arwa, that I have been wondering about is, do you think any of the contraceptives are torsadogenic? Or do you think birth control, low dose estrogen is relatively safe?
That's really a great question. Dr. Moss, together with our group, looked into that in 2013 or 2014, I believe, with a student named Shireen, and they published a very nice paper in Heart Rhythm that showed actually a hazard ratio of 0.98, and the P was very, very non-significant, which means that oral contraceptives were not associated with any with any cardiac events. I think the novel oral contraceptives mostly have a combination, not because of the QTC. People weren't worried about the QTC. People were worried about the cancer, the breast cancer, and therefore the evolution of the oral contraceptives went from single hormone to have a combination of the hormones, and this is what we have been speaking about all the time. If you have a good combination of the hormones, it should be safe. And we see this, that during the maturity, where the female reached this balance of hormones, a female has the lowest event rate, but the event rates tend to become higher where you don't have this balance. So I believe if a company will come with a medication that contains progesterone only levels, whether this might be protective, if we look at the lab, it might be. And whether a company will come with a estrogen driven only, or would this be arrhythmogenic? According to the lab, yes, in long QT2 patients. But the clinical practice and the truth and our data do not show this. They show that these drugs are safe.
And I think that's an important message, that low dose estrogen combination oral contraceptive is very, very safe.
Yes.
I was struck, Arwa, by your that it looks like if estrogen excess is torsadogenic, but I have one example and I never published it, and I'm curious whether Jeffrey has or anybody else, a young LQT2 woman with Depo-Provera. So Depo-Provera, in the arm,
Yes,
is a predominant progesterone. And yet we had two separate occasions where after the implant, she had a documented VF terminating shock. We then removed it. She went silent, and then we put it back. I didn't. She put it back in again, and she got another shock, and hasn't since she shifted to the more traditional oral contraceptive. And that didn't make sense to me because that was progesterone driven predominant, which I thought might be protective, but there is some evidence of progesterone blocking IKR. And I'm just curious your thoughts on that. And maybe even if, like Dr. Vineker and anybody has seen a similar example with Depo-Provera. So that's the one contraceptive based upon an N of 1 repeated twice that I encourage my young women who are choosing contraception not to go with Depo for now.
I agree completely with you, and I can see this happen. I discussed it 2 weeks ago with Dr. Goldenberg when I found this finding and tried to find a rationale. Why would an early menarche be protective? And then I was reading more about the progesterone and estrogen relation, and it's exactly what you said, Dr. Ackerman, is that if you give a patient, if we go back to the pathophysiology of the release of these hormones, estrogen and progesterone, we have the negative feedback system. So what would happen if you give progesterone in a very high dose? Automatically, our brain will increase the synthesis of estrogen through the negative feedback system. So, and then you have this imbalance again, and it's all about the imbalance. And I think that's why maybe, we don't know yet, but maybe there are two options that can explain these findings. Why would an early menarche be protective? One is that when I look over the years in the US and Europe, we see that women in general, and also our cohort, tend to have an earlier menarche. So our cohort of early menarche are the most recent patients where the treatment is better, where the application of beta blockers is better, where the ICD is more, where the sympathectomy is better. So and you have this trend about the menarche onset that occurred over the last decades. They say that for each decade you have 3 months of decrease in the average onset of menarche in the US. So this might be one explanation. The other explanation is that the thing that drives the bleeding and the period, because puberty occurs 2 years before the onset of menarche with the breast development and the Tanner stages. But then what happens, what leads to this bleeding and the menarche is actually a progesterone kick and not an estrogen. So perhaps these women tend to have a higher levels of progesterone at some point of their life, which led to this early menarche. But I think we are still not that in that level to draw conclusions based only on these numbers.
Thank you very much. Very good comments. I would like to bring one of the questions. There are several questions from the audience. One of the questions, which obviously is extremely important from therapeutic standpoint, about postpartum period. I believe in 95, with Dr. Eric Rashba as first author, we published a paper when we compare 9 months prior to pregnancy, 9 months of pregnancy, and 9 months of postpartum. And during this period, that it was mentioned by Dr. Younis, there is very significant increase in postpartum period, which was extremely well decreased by beta blocker treatment in that analysis. So we would like to stress, based on the question which was showing up, that treatment of beta blocker with beta blocker during postpartum period is very important, without much negative effects neither on mother or child who is being cared at that time. So we strongly recommend that this is definitely taken in postpartum, and definitely longer than for 9 months. Our analysis was based on identical 9 months period, but we would recommend longer treatment.
I think there, Wojciech, the other important thing is, so 3 years after that, as you know, in the very first issue of the new journal Heart Rhythm in 1998, we published showing that increased risk postpartum is almost exclusively confined to LQT2 women.
Yes.
So very uncommon out there for the LQT1 and 3 and others. And so LQT2 women in the postpartum period, we have to have your treatment really well in place. I've seen it said that the postpartum period in LQT2 women is an extremely dangerous window of time. And I don't think that's true. I don't think we should refer to it as extremely dangerous. I think that sends the wrong message to the families, as opposed to saying it clearly is a higher torsadogenic window of time, almost higher than any other specific period of time, like you said, Dr. Younis showed, but it's not a spooky. I mean, 14 out of 100 is 14%. That's not like 99%. So I tell our families it's a higher window of time of risk. We better have our game on. If we were on lower dose beta blocker for whatever reason, quality of life, and now we're heading postpartum, we better up our beta blocker therapy and get it into good treatment dosing range out of respect for that higher risk window of time, not spooky risk window of time.
I agree with you, Dr. Ackerman, and I think it's also important to highlight the fact that most of these events that occur during the the postpartum period are driven by syncope, by fainting, which is also happens to be higher than normal among postpartum non-long QT. The woman she's breastfeeding, waking up at night, dehydrated, and then you have a high rate of fainting. So we need also to think that the risk of life-threatening events during postpartum, as Dr. Ackerman said, is higher than during maturity, but still low.
Thank you. Ilan, will we move forward?
Yes, I believe so. And thank you, Younis, Dr. Arwa. It was a great talk and comprehensive overview of this very important topic. Dr. Zoriba will be our next speaker. Everybody, there's no need for introduction, but I will introduce him. Professor of Medicine. He has been the director of the Heart Research Follow-up. He's currently the director of the Rochester LKTS Registry. He's a world-renowned cardiologist in the field of non-invasive arrhythmia monitoring. So Wojciech, the podium is yours.